All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today we're going to talk about the long haul protocol that was just published on FLCCC site. I was with them in that discussion as well. I'm quite humbled and blessed that we together, the cool beans, remember a few weeks ago, we went over the long haul protocol. We built on top of it. So this was really a combined effort in this community here. And I'm grateful for that. I think we are the only community who has been doing this work together. It is not that a doctor is doing something and then sharing. It is this community working together, and I love it. So thank you very much, and congratulations to everyone that there is hope. There is a beginning for a better outcome for those who are long haulers, either because of the COVID or because of the vaccine. So thank you very much for doing this. And the discussion that I want to do today is one, I want to go over that document so that when you're talking with your physician to say, I want to follow this protocol, you know that what are the decision points in there. Secondly, a few cool beans here. I want to just very quickly call out. So I'm going to share my screen. So cool beans, I hope Jenna is doing good and recovering. So that is one. So prayers for Jenna. Margaret, I spoke with her as well today. Her phone is still, it is stuck on the Apple's logo and it doesn't go any further from there. So she is, I think at this time, she's probably taken it to some local Best Buy to help. Jim, I haven't seen Jim for a couple of days. He was here before, so I hope he's okay. Last time when he was absent for some days, there was a health issue. So I hope he's okay. France, I used to be, is it me who missed France today and yesterday? So I hope she's okay. Carly, I saw your message that you are going to go to a doctor 4 hours drive. So good luck and hope that you recover quickly and rapidly. Arubaga, I just saw your message that you are recovering from the post-vaccine symptoms. So good. And Texas, I saw your message that you're finding it difficult to read or write. Is that because of the MCAS? So prayers for all of you. Just very quickly, if we start from here, so real gifts for the humanity, and I want to go over the protocol itself. So here is the protocol on FLCCC site. I want to read some parts of it. Of course, I was working with this one for some days. This protocol was built on top of this discussion, April 29, 2021, where we went over various things. So you are aware of this. There is another video with this as well. I want to just look at this one. So here the approach outlined below is consensus protocol based on a collaboration led by Mobeen Sayed, Dr. Bean, yours truly over here. And then we had Dr. Ram Yugandhra, Dr. Bruce Patterson, Dr. Tina Pierce, and the FLCCC. Protocol is the following. And now I can actually, as more pathologies are coming together, coming to surface or are being revealed, we can kind of understand why this protocol worked. As Dr. Corey was talking about this as well, that when the protocol was coming together, this was mostly clinical. It was the observations of the doctors who are practicing. Fortunately, those doctors who had the courage to use ivermectins and hydroxys and zincs and those newer things, those who were not working on those things were not able to contribute or figure out how to manage. Meaning this was just, if I was using ivermectin, only then I would dare to try it in a long haul state as well. So it was just interesting that clinically, I was seeing that patients are not becoming long haulers. So now for me, direct patients, only three out of hundreds. And then hundreds of long haulers who are not my patients. And I had been using steroids and I had been using ivermectin. Now it actually makes more sense for why that was happening. So I wanted to discuss that today, that what was the background to this. Roman, everything okay? I'm seeing folks. Um, what happened, Roman? I'm just scrolling through the. Roman, that is so sad. Just look at your comment here. Why did this happen? And how can we be of assistance at this time? So please stay in touch. You have my Discord as well. If I can share my phone number too, if you would like to talk. And stay strong. I have seen in my life, and I'm telling you the truth, this is not something to just try to, these are not words. This is my learning in my life. Every time when something bad happened, and I thought, this is it, this is the end of the world for me, I always felt that the world actually became better once I had gone past that adversity. So there is always something better that is going to happen when there is some adversity. So please stay strong. It sucks when we are going through that time, but there are always better doors that open. There are always better gifts that arrive. And I had become so much believer of this state of affairs that in the beginning, when I was younger and I would write code, computer software, sometimes we would lose it. Those computers in those early days and those plastic disks would lose code very often. And I had found out that every time I'll rework something, I would do it better. And so I had become used to saying, fine, the code is gone, it sucks, but I'm going to do again and it would be better. So I know that you are going to pull through this and you would actually become and have even better gifts. So please do reach out, and not to not discuss about the situation with you, Roman, and try to say, here is something that I experienced. But in my life, I had, coming from a broken family in a very young age, used to be thrown out on streets very commonly. Whenever the family would not be able to handle situations or the elders are just disagreeing with each other, we would end up on the roads. And every time that would happen, there would be something better that would happen afterwards. During that time, it would look like, that's it, finished, done. This is it. All confidence gone, all trust gone, all motivation, inspiration, everything gets shattered. But then when the pieces are put together and you are rebuilt, it's beautiful. And you move forward even with more strength and more shine, more grace. So more success to you. I can assure you that that would come, and better than now. So let's talk about this. So the reasons that we saw clinically ivermectin working and steroids working, I want to explain now in the light of newer pathologies that we are recognizing that are part of the long COVID. So here are the pathologies and why it makes sense. So one pathology, so Dr. Bruce Patterson's team, they have come back and they've said that, hey, in the monocytes, they see spike proteins. And spike proteins hanging out there in the monocytes. Now, monocytes, and I would do a complete discussion about this. I was actually preparing this, but today's day was crazy. In the morning meetings, then the FLCCC, and now here we are. So I didn't have sufficient time to complete one topic, and this is a rigorous topic. So anyways, monocytes come in the blood from the bone marrow. And then what monocytes do is that they themselves can be polarized, meaning they can be in two states. There is a state in which they are reactive. They are what we say is pro-inflammatory. And they are creating cytokines that are going to cause inflammation. They themselves would become cells that would fight. So they're pro-inflammatory. Monocytes can also be in an anti-inflammatory state, although it is not called anti-inflammatory state. Instead, it is, in the case of macrophages, it is called non-classical state. So I'm just going to use anti-inflammatory state as a loose representation of non-classical state. And this anti-inflammatory state is when monocyte, instead of getting ready to fight, it becomes ready to repair. And there is a difference. Imagine army in a country, any country. Army usually is ready to fight, and they do go and they fight, and all that fighting occurs and killing occurs, defense occurs, offense occurs. And then if there is some crisis within the country, then the army can actually switch role from fighters to helpers. And now they are in a flooded area, they're going with boats and they're getting people out, and they're going with the choppers and getting people out, or in an area of disaster, they're going and doing services and building bridges and all those things. Imagine that is an anti-inflammatory role. Monocytes can be in this repair role, or they can be in a fight mode. The problem is that if monocytes have something in them that is bothering them, for example, spike proteins, then they would continue to stay in a fight mode. And that is how the inflammation would continue to occur. One part, so hold this much of the thought, and I want to connect it to one more thing. And I would do a complete discussion about it separately, but just giving a hint why this protocol can actually be very useful and why we saw it clinically working. These monocytes, they are usually in the blood vessels. Now, if there is some area of the tissue, let's say lungs, or let's say the throat area, where there is a virus and the tissue damage is occurring, and the damaged tissue and the local immune systems, for example, macrophages and neutrophils and the dendritic cells and other cells are creating, and the cells that are breaking down, they are creating cytokines and chemokines, and there's a fight occurring, then this local blood vessel will have those chemokines spilling in the blood vessel and cytokines. Those blood vessel, imagine a blood vessel having a tiny, tiny shade of these cytokines present in that area. So when monocytes would pass near that, they will become interested in the fighting area, and they would get out of the blood vessel and they would go here. When monocytes get out of the blood vessels, they're called macrophages. So that means a monocyte state can be translated to a macrophage state, and now that means we have macrophage in these two states as well. One is called classical state or pro-inflammatory state, where we say macrophage is active. And I'll explain later on what active means. At this time, or how activation occurs, at this time, this is enough to say macrophages can be in an M1 state, and they're active. And when they're active, not only they are killing the cells, they're also releasing cytokines that would continue to amplify the immune system to fight there. Hope is that at some point this fight will go away. But this is how the macrophages are doing. At some point, the macrophages have to convert, or new macrophages have to be formed that are in M2 state or in a non-classical state. I'm again going to use a loose term here, and that is anti-inflammatory state. These macrophages will be in a state of repair and remodeling. What does that mean? They don't want to fight anymore. They don't want to break anything anymore. They do not want to eat anything anymore. Instead, they would help lay down the collagen. Collagen is, imagine the road work and the material, raw material for the tissue. So they'll help lay down the collagen. They would help stimulate the fibroblasts. Fibroblasts are the cells in the tissue which would help make the scar tissue and the fibrous tissue and help repair the system. And when they are in the repair and remodeling, then macrophages are not inflammatory. Good. So monocyte, macrophage, similar behavior. Monocyte is monocyte when it is inside the blood vessel. When it comes out of the blood vessel, it becomes a macrophage. There can also be, so now this is an important point I'm going to say. There can also be macrophages in the tissue that are not derived from monocyte. These macrophages were in us when we were being formed in our mothers. And at that time, the yolk sac, so yolk sac, if we think ourselves to be an embryo, so let's say this is an embryo. I love embryology. And so let's say this is an embryo. This piece here is the embryo developing us. And this piece here is the yolk sac. From this yolk sac, macrophages are formed from parts of the yolk sac that migrate into the embryo's body, and then they live in our tissues as macrophages forever. And I'll explain why forever. Then as the baby starts forming further and a fetal liver is formed, this fetal liver also makes macrophages that would migrate in the body and live there forever. Now the question, why would they live forever? Are there macrophages that are like 100 years old with us? Cells cannot live that long. So yes, you're correct. These macrophages have renewal capability. They are like, I shouldn't call them stem cells. Stem cells means the cells that not only make other kinds of cells, but themselves. So here we are saying renewal, because these macrophages will not make other kind of cells. They would only make themselves. So the macrophages that are sitting here are of two types. They also have some functional differences, but I'm going to leave that. We would still go back to the same point that the macrophages can be M1 and M2. Here is the same is the case with the monocytes. Now here is the important thing. Macrophage that is stuck in M1 state, that is pro-inflammatory state, would continue to become active. And if it does not switch off, either die and get out, or removed by the other immune systems, or converted from active state to the repair state, or from M1 to M2, then that macrophage has become dysregulated and is causing damage. Why is it doing it? Because the parent of the macrophage, I shouldn't call it parent, but the macrophage, imagine macrophage is from a different country. The country is bone marrow land. And then the tissue land is another country. So it is really just the same person. It immigrated into another country and is called something else. For example, I came here from Pakistan. So now I'm an American, but I'm still the same Mubin. As a person, I'm Mubin. That is the same thing here. Macrophage sitting in the bone marrow, in the blood, is monocyte. And this monocyte is bothered by the spike protein in it. So here are a couple of interesting things. In this discussion, I've eaten up a lot of material. For example, the life of the monocyte, the life of a macrophage, how macrophage become active, how they convert from M1 to M2. I want to do a separate complete topic, but here for the long haulers, I want to connect some points here. Number one, ivermectin worked because ivermectin binds with the spike protein. So here is the spike protein, and we know that ivermectin binds with this spike protein. We know the ivermectin man does it. This is the ivermectin man, right? So we know it binds with that, and it binds with ACE2 as well. So that is one role. Now, if you think about it, if a spike protein is present here inside a cell, ivermectin actually goes inside the cells. So accidentally, not knowingly, we still did the right thing, and we kept using ivermectin, and those spike proteins that were hanging out there inside the cell, the debris inside the cell, as Paul Manek used to call it. Now it is from Bruce Patterson's work, it is known that it is spike protein. That debris inside was handled by ivermectin and not by other things. That is why other anti-inflammatories were not working very well, because ivermectin has a direct role to work with the spike protein. Beautiful. I loved it when I look at the whole pathology and when we were working on this protocol. So that is one. Second part, why do steroids work in this situation? So to talk about steroids, I also want to discuss this. Doctors, nurses, healthcare workers will know what I'm going to say now. Many times when doctors have less control over something, they start giving steroids. Not in this country, in the US, but many places in the world. The result is that steroid use can become abusive, and it just becomes a band-aid on the system while we do not know underneath what is going on. It is still used in certain diseases where we do not know exactly what's going on underneath, and we give steroid because at least it keeps the inflammatory system under control. Here, when we were using steroids, once again, my reasoning at that time was that it seems like immune system becomes dysregulated and we allow it to calm down, and that would make it better. And I think you may have heard this statement again and again, that allow the immune system to calm down. It actually is, I can now provide a more sophisticated answer, and that is that steroids actually go in, and let's say the macrophage is sitting in M1 state, in this angry state. For a macrophage to get out of the angry state, we have to calm down the immune system and the cytokines and the cells that are bothering it by connecting with it and activating it. For example, the T helper cells, especially T helper 1 pathway cells, they produce interferon gamma that bothers macrophage and activates it. The T helper 2 pathway, they produce interleukin 10 and others that try to convert macrophage towards M2. So if you allow the immune system to kind of reduce its function, that allows an M1 macrophage to relax, rest, and say, all right, not a lot of things to ask me to do function. I'm going to start becoming more open to conversion to M2. So administering steroids actually reduces the cytokine productions. It suppresses the immune system's activity, which reduces the cells from talking to each other, which reduces interleukins production, cytokine production to be low. The result is that macrophage get a rest. When they get a rest, when they are in a state of a little bit more calm, they're not in the middle of a war, or they do not have this post-traumatic syndrome, they can come out of M1 state, respond to the things that are asking them to come out from M1 to M2, and they can become M2 and start taking care of the repair part, and the long hauling would go away. So it is very important to understand how the ivermectin and steroid worked. Now, a couple of more things. I think this community that is listening to this talk is going to be the first community on the face of this earth who knows what is going on with long hauler and how to modulate the long hauler. Here is the second part, the role of vitamin C and vitamin D. Vitamin C, its function, and I have all those studies and I intend to have these discussions in detail. Today, I had less time, so I'm just presenting without all those study and drawings. Vitamin C, its function is to convert high-dose vitamin C, or actually high-dose ascorbic acid. Slightly different from just calling it vitamin C. High-dose ascorbic acid's function is to convert an active macrophage to a more docile, repair, remodeling intent macrophage, intent on doing good. It is ascorbic acid is its job. So imagine somebody who's in an acute state, acute COVID. You give them high dose ascorbic acid, it is going to convert their M1s to M2, reduce the anger of the macrophage, reduce their wrath, and improve the patient. Same is true for the long haul as well. Once the macrophage have become upset, then to bring them to normalcy, we give them ascorbic acid. But don't give them vitamin D. So reducing vitamin D would actually help long haulers. Do you know why? Vitamin D's function is to convert an M2 to M1. Vitamin D helps with the macrophage activation. So think about it for a second. Where will vitamin D useful and where will vitamin C useful? If I create a disease progress here, I'm happy and proud to discuss this with this thought that we will know how to look at it, and this will be an asset for so many. So look, let's say this is disease. So let's say we are in prophylaxis first. So no disease, there is a chance of disease, and we want to keep our immune system healthy. Then there is acute disease. Then there is long haul. Vitamin D works here. Why? Because it has many functions. We know that, including modulation of the immune system, adaptive arm T helper cells, their modulation, cytotoxic T cells modulation, nuclear factor kappa B's modulation. So vitamin D does a lot of things. And another important thing is it would keep M1 states alive of macrophages. It would keep macrophages in a higher alert state. And macrophages would do, and monocytes as well, will do more sentinel activity, more guard activity, more patrolling activity. They have seen that the active monocytes can actually crawl next to the blood vessels walls, just like the old time guards used to be standing and walking and patrolling on the forts. Monocytes can actually be crawling on the sides of the blood vessels to patrol for anything wrong. And vitamin D enables macrophages and monocytes to do that. Do we need this? Yes. Would the people become long haulers? No, because these things are not triggered badly. They would actually prevent the disease now or help reduce the disease because they're patrolling, they're alert. So it is great to have vitamin D here. Acute disease. Acute disease have two phases. Acute viral stage and then cytokine stage. In the acute viral stage, it is actually very interesting to give vitamin D because that would help with M1. But if we think that the patient is going to end up in the cytokine storm, that means dysregulation, then all of a sudden vitamin D is less important and vitamin C high dose is greatly important, ascorbic acid, because it is going to now start calming down the M1s who have become angry, who have become too much in number because they have renewal capabilities and they're just attacking the system. So that means we cannot just blindly give vitamin D and vitamin C together in all stages. And then if the dysregulation has occurred, if the macrophages have forgotten their path and they have become M1 and just continuously bothering us, or there are spike proteins in the monocytes, which then is reflected in the macrophage being bothered, then vitamin C, ascorbic acid, would help. With that, of course, statins would help. Melatonin would help. And I've done a discussion how melatonin helps. It actually restores cells' behavior towards anti-inflammation. Ivermectin will help by blocking the spike proteins. Steroids would help by calming down the system so M1s can give up and say, okay, fine, we're going to become M2. This is why steroids, doctors have been pondering that why do steroids work when the patient's lungs do not show enough damage to say steroids are useful. So why were the steroids working? They were working because they were helping with the modulation of the immune systems, the macrophages inactivity or dysregulated activity. So vitamin C, vitamin D, ivermectin, and steroids are paramount to understand how this would work. Now, if I continue, so here how we are starting is start with ivermectin. Right away, if the ivermectin starts helping, we know that this is a viral debris problem, possibly spike protein problem. If there is nervous system signs and symptoms, then fluvoxamine, because ivermectin does not cross the blood-brain barrier. If fluvoxamine is not something you want to do, then steroids, because steroids would help on the brain inflammation as well. Then corticosteroids, as I just discussed. With this modulation of vitamin C and D, vitamin D at the RDA, daily RDAs, not 10,000, not 20,000, but normal, and keeping the vitamin D levels in the sufficiency state, that means 30 to 40 and above. So if somebody has vitamin D level that is 6, then they would have to take a higher dose of vitamin D to bring them up to normal state. But if they are in a good state, then don't give too much vitamin D because it would cause M1s to become active or stay active. Instead, give them vitamin C. And vitamin C would convert M1 to M2. So if you see here, corticosteroid, then for the macrophages, if this is macrophage, vitamin C, omega-3, statins, and melatonin. Now, imagine with these, you are still not getting good results. That means it may not be the spike protein sitting in a monocyte. It may not be a macrophage that is upset. It may be that the person's mast cell problem has become poked, triggered, or unmasked. And so in that case, the mast cell stabilization and mast cell activation syndrome management needs to be done. Important thing now is to not do them all together. The reason for that is that if that is all done together, we will not really know what are we addressing. Are we addressing spike proteins in the monocytes? Or are we addressing viral hit and run, which is a separate mechanism? I didn't discuss it today because I wanted to discuss this macrophage part first. Are we addressing viral hit and run? Viral hit and run only addressed by steroids. Ivermectin will not have much there. Viral debris with the dysregulation of ivermectin plus steroids. Neurological symptoms, fluvoxamine. And if there is mast cell activation syndrome on top of this, or other problems are not there, just the mast cell activation syndrome, then antihistamines like things. So the important thing is to kind of go in a more methodical way to try to understand which area is helping the most, what drug adding or removing is helping. So start with ivermectin, then if needed still ivermectin and steroids, then if still needed ivermectin, steroid, and then maybe vitamin C or ascorbic acid or statins or those fluvoxamine, vitamin C or ascorbic acid, melatonin. Melatonin, I believe, should be in all cases. And then maybe add or just have MCAS management. So that is the basic structure of approaching a long haul. As there is more pathology that would become clear, we will know more and we'll continue to refine it. But I hope this makes sense. I wanted to make sure that we understand the role of steroids and ivermectin and vitamin C and vitamin D. Going back here, this dose here for vitamin D is lower, but I actually like this to be a little lower if this is a macrophage activation syndrome, because the primary thing that should work is ascorbic acid, and the vitamin D should be actually kept lower. So this is the long haul. One more quick announcement. So this is the Treat the Long COVID conference that would occur on this Saturday. So 2 days and 12 hours. I am presenting the same thing that I'm presenting here, and that is the one that I presented in FLCCC's talk as well, and that is the management of the long haul. And again, this is not just me. The management got pulled together by the work of Dr. Yo and his team, by the work of Dr. Tina Pierce and her team members, me, and then FLCCC. So this was a combined effort, but I'm really blessed that there is a start that we have. Now let's do this. I'm gonna, yes, so this is very important. So Roman, I was gonna actually talk about this. So there are some special cases that we should be aware of, and I believe I had talked about them in the protocol. However, FLCCC thought that that is a lot of extra minor things. So here is an important thing. Number one, anosmia. Roman brought it up, so I had forgotten, although I'd written this note over here. So anosmia. Without fail, I have seen that whenever somebody is suffering from anosmia or smell and taste issue, if you give them high dose ivermectin, 0.4 to 0.6, I have been using 0.3 to 0.4 as high dose, but there are doctors who are giving higher. Within 2 to 3 days, anosmia starts reversing or disappears. Before that, it could be persisting there for months. This is how magical the response is. So this is one. Anosmia mostly handled by high dose ivermectin. If not that, then add steroid with ivermectin. Don't leave ivermectin out. Fluvoxamine has been very useful for the tinnitus and other neurological symptoms. In some cases, there have been some cool beans who said, my tinnitus actually increased, so had to reduce fluvoxamine and go to histamines, antihistamines. Macrophage activation syndrome, we talked about vitamin C and D. Spikes from vaccine, same problem as the other. Now, I was thinking about something. So I think today's talk, once again, is it has a lot of very important information. Here is another thing that I hope, I wished I knew this before, and that is actually my ignorance or my lack of curiosity. And I wish that others who are fear-mongering a lot of people at this time, they would see that too. The spike protein in all vaccines, let me see if I can find a link to show you. So it's not just Mubin saying something. Okay. If we look at this one, and I would explain this separately as well, I was going to explain this in terms of the folks saying the soluble spike proteins and spike proteins here and spike protein there, and we have a problem. And I was researching and I found something that is just so simple, and I do not know why I missed it, but I missed it. So look at this paper. This is December 2020, right? Then there is August 2020. In this paper, this is, and there are more papers from 2015 as well that are in my list here. This one, SARS-CoV-2 mRNA vaccine design enabled by prototype pathogen preparedness. And if I actually go down to the bottom of this one, you would actually see here spike protein as well. Prefusion. So look at this one. This is 2016's paper talking about prefusion structure of a human coronavirus spike protein. This was in Nature. And you would see a lot of those here from 2015 and 16 and onwards. What are they talking about? What they're talking about is the following. All the spike proteins in the messenger RNA vaccines and in Novavax are actually prefusion locked. And Doug said that yesterday as well. Remember, Doug was talking about it too. So they're all prefusion locked. That means they all cannot open up and fuse with the cell and cause the damage that fusion of the cell will cause. And so that idea of somehow the spike protein is causing endothelial problem and the spike is coming from the vaccine is kind of still needs more merit because the spike is actually locked. It is not going to bind with ACE2 in the ovary or in the liver or in the endothelium or some other places. So then when I was reading this is today. When I was reading this, the question that was coming to my mind is, then why is the spike protein causing a problem in vaccinated people? Because there are some vaccinated folks who have long haul like outcomes. And that surely is going to be because of spike protein. They do not have anything else. Maybe adjuvants too. So that was in my head when I was thinking about this. And then it clicked. This locked spike protein is actually picked up by these macrophages as well. That is a job. And if then they are renewing, or if the monocytes have the spike protein in them, and those are becoming macrophages, then once again we end up in the macrophage activation syndrome. So it is not the spike protein going and destroying the endothelial system or causing those things. It is the spike protein ending up in the immune cells, which it is supposed to end up in there, and then bothering them enough to cause similar M1 activation as infection does. This is possible that a locked spike protein can do this, but a locked spike protein cannot go and do other kinds of damages. This also makes sense because spike protein is actually not supposed to get out and run around in the body. Even when there is some that is gotten out from the broken cells, or let's say damaged spike protein DNA, and it got without the anchor left out in the body as secreted, that still is going to be less and very rare. But there are people who have the symptom. So that is now, to me, it is understandable that, all right, so the spike protein is actually in the cells, and those are the immune system cells. And when they're bothered, they're keeping themselves in the pro-inflammatory state, and that is what is causing those symptoms. This is why post-vaccine symptoms are also managed well with ivermectin and with steroids and with fluvoxamine-like things. So I was actually preparing this one as well, the spike protein and how the vaccines have them. So I actually went and read Moderna's patents too. I actually had just to prove it that I did, I have the link here. So this is the Moderna's patents, and these are all their patent documents. The most interesting, I believe, is this one. I think so. So I had to look at their documents. Then I had to look at these studies. Turned out that locking of the spike protein idea is not new. It has been out there since 2016, 15, and before, when there were vaccines being made for SARS-CoV-1 and MERS-CoV. And this problem was being solved at that time, that we do not want to create spike proteins that would go and bind with the ACEs and other things. We want to have a spike protein that would not do it. We just saw that with Novavax yesterday. Then Doug asked this question. Then it was bothering me as well that, hey, why didn't I see this? Doug then put the answer here as well to say, this is Doug Gross we're talking about. And he said that, hey, it is locked for both messenger RNA vaccines. At least that's what I read as it was going fast here. So that also solves this mystery. So I'm gonna stop here. You can see that I am a little more excited to. There are so many things that have come together that I think it was important to discuss it. Okay, so I'm gonna answer some questions here. Let's just make this one discussion, and I would stop after this. Please remember, tomorrow we'll have Dr. Professor Eli Schwartz from Israel talking about Ivermectin study at 11 a.m. Pacific time. So please join me at that time. Let me answer some of the questions. It's just that I have been sitting at this chair since 3:30, and before for preparation. The things that you are listening was a preparation throughout the day. So continuing to sit for a longer period of time may not be as easy. So give me this flexibility to present this and then stop. Let's just answer some of the questions. Heather, Dr. Drbeen, I have low-grade fever for 3 months now. Why? So that is, again, an indication of the inflammatory cytokines being produced. Low-grade fever is the inflammatory cytokines coming primarily from the macrophages. The remaining immune system can produce cytokines too. So that means the discussion I just did, ivermectin and steroids, should actually help. So Satish says, will spike protein make blockade inside your blood vessel? So I just discussed it. It is in a locked state, so no. Red Pool Jack says, Dr. Bean, why are we still wasting our existence over this when the US death rate for 20 was the lowest year of the last? So please, totally up to you to listen to this or not, but there are people who need help at this time, and I think it is important to discuss these things. Eileen says, will the TLC conference be recorded? Thanks. So Dr. Tina Pierce is doing it. I would hope that she would record it and then put it up somewhere as well. Don't know. So Andrew says, why is this type of vaccine better than traditional vaccine like Sinopharm? And result is basically the same. No. So really, the way to look at vaccines is to look at their efficacies and side effects. New or old at this time is not that interesting for me. I know it is very interesting for many people, but not for me. For me, what is more important is, what are the side effects? What are the mechanism of actions? What is the efficacy? So for example, if somebody offered me weekend SARS-CoV-2 traditional vaccine, I would run away. I don't want to have weekend or live SARS-CoV-2. So I think this is the way to look at it. Louis says, can we look at the time when to reduce D and increase C? I assume this goes for active initial infection, inflammatory phase, signs, symptoms to be. So very simple. First, keep the vitamin D at 40 and above. If it is below any time, it should be above. Second, during the long haul, which becomes a chronic state, don't do too much vitamin D. Do vitamin C or combine them. In the acute disease, the early part of the disease, vitamin D is important to give so that the immune system is regulated correctly. But then ascorbic acid is also important, maybe 5 days and onwards. So first maybe vitamin C's and then ascorbic acid if there are symptoms of symptoms of cytokine storm. That means D dimers are there and the ferritin is there and so on. So there is that modulation to do. Navarro 95 Eric says, my GERD got extremely. Let's do this. I'm going to hang up and let's do a chit chat, because this video, I really want people to be able to watch this. It is going to be helpful. If it becomes too long, people don't even touch it. So give me a second. I'm going to hang up and then I'll come back. Do me a favor, please like, subscribe, and share. One, and second, if you would like to support this work, there are 3 links in the description. One is to buy me a coffee. One, if you would be okay with PayPal, then you can support using PayPal links, or you can be a patron as well. So thank you very much. Let me come back and we'll continue our discussion. Please hold your questions and bring them to the next talk.